I'm Seydou Doumbia. I'm the program director of West Africa ICEMR and the director of University Clinical Research at the University of Science, Technique and Technology of Bamako. So I will first present an overview of Mali, West African ICEMR. And I will also present the changing epidemiology of malaria in relation with malaria control intervention in Mali in the past decade. And I will be followed by my colleague Nafumo Sogoba, who will present the challenge and opportunity in vector control in Mali. And Dr. Toure will present the key finding of our implementation research aim to improve our SMC in Mali. So I think this morning has been shown that globally the malaria burden continues to decrease, but unfortunately Africa carries most of the burden of the disease, with more than 90% of cases in the African region. In Mali, malaria remains the leading cause of morbidity, and it's highly endemic in many parts of the country. With low endemicity in Bamako, the capital city, and in the desertic area in northern parts where malaria occurs as an epidemic. So this ICEMR was built on the observation we made from the first round of ICEMR between 2010 and 2017. And this challenge includes the high prevalence of infection and incidence, despite the wide deployment of malaria control intervention, as I have seen also in Malawi. And also we have seen an upward shift of the prevalence of malaria infection and incidence from children under 5 to older children. And we have seen also an increase in outdoor biting rates and entomological inoculation compared to indoor biting. And finally, the widespread of insecticide resistance across the study area. So the overall goal of this ICEMR is to study the effectiveness of current control intervention and their effects on the dynamic of the interaction between parasites, the vector, and human in 3 ecological settings. The ICEMR include 3 projects. The epidemiology projects, which study the different pattern of malaria epidemiology to understand why malaria is still persistent despite the use of several control strategies. And the immunogenetic projects, which examine the genetic diversity of malaria parasites and the drug resistance and immunological aspects of related to the control intervention. And the vector ecology projects, which investigates the source and the survival strategy of malaria vector population during the long dry season and their impact on malaria transmission. So our ICEMR was designed to respond to the research need of the malaria control program. And it's also match to the PMI strategy of to end malaria in Mali. The vector control, on the vector control side, so the ICEMR is providing longitudinal entomological survey data and data on insecticide resistance to the national control program to support the bed net distribution and the entomological monitoring. In terms of case management and drug efficacy and the drug-based prevention, such as SMC, so we are carrying out implementation research to guide the intervention. We are also conducting drug resistance studies, and we have a longitudinal cohort studies which provide real-time information on the incidence and the prevalence of malaria, and provide also entomological information on entomological indicator and drug resistance to support the strategic information for the National Malaria Control Program. So the study sites include 3 sites, Dangassa, which is in the southern part of Mali in Sudan Savannah, and Koulikoro, which is in much drier area, and Joro, which is located in an irrigated area. So in terms of control intervention, we are monitoring 4 major intervention in Mali, the malaria treatment using ACTs, universal coverage with bed nets, which started in 2012, but started earlier in one of our sites, the Joro site in 2008, with a Millennium Challenge Village project. And the IRS, which has been implemented in our study sites between 2008 to 2016, but has now shifted in the central Mali in Mopti area, and the SMC, which started in 2015 across the 3 study sites. In terms of study design, we are using cross-sectional surveys, 2 cross-sectional surveys here at the beginning of malaria transmission season in June, and at the end of malaria transmission season in October, and which help us to determine any change in the asymptomatic P. falciparum infection rate, and provide also some sample for immunological and genetical studies for Project 2. And we are carrying out the passive case detection in the 3 sites at the health clinic, following up 1,500 children and adults to determine the incidence of malaria, so that we can provide information on change of in the incidence of malaria as a result of the intervention. And finally, we in parallel to the cross-sectional survey in human, we also carry out a cross-sectional survey, entomological survey in June and October to determine any change in entomological inoculation rates. So I'm sharing some of the results. As I said, you can see the change in the prevalence of malaria infection in the dynamic cohorts we have been following up. So when you look at the baseline data in 2014, where in Dangassa we used to have a high prevalence of malaria infection, more than 60% at the beginning of malaria transmission season, but you can see that it has started decreasing in 2015, and from 30% to 4% in 2021. And this also because we in 2015 SMC started, and universal coverage also has been, distribution has been done in 2015. So at the end of malaria transmission season, if you look at the first 3 years of the baseline, from 2012 to 2015, malaria transmission was kind of stable, but it started decreasing after 2015 from 60s to 18% in 2020. So this trend is continuous. This has been published recently in the Malaria Journal. So we have looking at also the change, this change across age and across time. So if you look at for the children under 5, so we see the same trends from baseline from 2012 to 2015. We see a decrease after 2015 from 50s to now 20s, around 20% prevalence of infection. And when you look at also for the age, older children and adults, we see the same decrease over time. But what is very important also is that for adults over 20-year-old, so we see the decrease, but we still have a quite number of infection among adults, around 10%. Still, the infection is persisting among adults. The shifts in age is illustrated also in this different figure, when you also see that we see that the burden of the disease is mostly across years. We see that the burden of the disease is in older children, 5 to 9 and 10 to 15-year-old, and starts also even shifting again to 15 to 20-year-old. So this trend is observed in the 2 sites of Dangassa and Joro site of Koila. In terms of incidence of a disease, we can also see that malaria, the incidence, malaria remains highly seasonal in Mali, from January to June, which correspond to the dry season. You can see that the incidence is very low, but starts increasing in June. June corresponds to the start of the rainy season, and reach the peak in October, and starts decreasing from October to December. But still in November and December, we still see quite a high incidence of malaria, which also from this data, we design an implementation research on SMC. SMC is provided for around from July to October, but because of the high incidence we observe after November, so we decided to test the efficacy of 5 rounds of SMC, and this result will be presented by my colleague, Dr. Toure. Looking at also the spatial distribution and the spatial and temporal distribution of malaria cases, particularly the infection, we have focused on the dry season, when you see that Mali has a long dry season starting from November to June. But we see that during this low transmission season, that malaria infection cases are are clustered in different study area. Even though during also the rainy season, we see some cluster, but the most important here is that these different cluster we have seen provide an opportunity also to guide the malaria control, which can be focused also on the dry season in terms of vector control and also in terms of reactive case treatment during the dry season to prevent the spread of malaria from the dry season to the wet season. We have looking at also the impact of specific malaria intervention on the disease. This is the impact of IRS we have demonstrated in the study site of Koulikoro, where IRS was performed between 2012 and 2016. We compare area where IRS was implemented and in the neighboring area where there was no IRS, and you can see that the incidence was much higher, as much as more than twice in area where IRS was not implemented compared to the IRS area. And this seven figure also illustrate looking at in terms of time to events that children living in the IRS area were less likely to develop malaria earlier comparing to the children living in no-IRS area. Looking at also the trend of malaria, as I showed earlier, in terms of incidence of malaria after the introduction of SMC in 2015, you can see comparing to the baseline of 2013, when you compare the incidence, you can see a decrease of the incidence where after the introduction of SMC. In 2016, we observed more than 70% reduction in the incidence of malaria. And this has been observed in September and in the October and November. But what you can see also is that after that in December, we don't see any specific impact of this decrease. The incidence remaining similar between the baseline and 2016. So which also justify the expansion of SMC to 5 rounds. What about the drug use also in terms of resistance to provide information to the National Malaria Control Program? And in our study sites, we have looking at also the different drug use for malaria control in Mali. You can see that the parasite remain highly sensitive to this different drug we use, but we see also a kind of reversal of the sensibility of to chloroquine, but the sensitivity was low with the quinine. We have been also looking at the different molecular marker of the resistance, and so you can also see that in Dangassa, in one of our study sites, we see a high prevalence of chloroquine and pyrimethamine resistance markers, and we have also seen a high proportion of the number of codon substitution rates in the sulfadoxine pyrimethamine resistance genes in our study sites, and we have selected one of the site, which is Nyoro in northern part of Mali, not part of our study site, but we see similar trend as well. So in conclusion, what we see that this ICEMR study revealed that the expansion and the enhancement of ongoing control intervention strategy, such as the universal coverage in bed nets and SMC, have significantly contributed to reduce the burden of malaria in Mali. Despite this progress described here, the persistence of residual human reservoir of parasite carrier, and particularly in older children and adults, is also some concern. And this, in addition to the circulating malaria vector in the study area, highlight the need to consider to not only to strengthen the current strategy, but also to consider over innovative approach to further disrupt malaria transmission. The high malaria transmission rates in the field sites also here provide opportunity to evaluate a new control strategy in this high endemic area for us to be able to end malaria. I would like to thank the ICEMR program, the scientific advisory group for their continued advice, and also the PMI, who has been very supportive to providing drug supplies to our implementation research. Like to pay tribute to Don Crostat, whose effort laid the ground for this ICEMR, and also would like to thank my colleague from the Over Consortium, and again thanks John Hopkins for providing this platform to share information across ICEMR. Thank you.